So welcome friends. I hope most of you are watching the Sensational 6 series of previous year questions. So now we are discussing today a very important topic on yes. Yes. So welcome friends. Today's session is I'm going to go live. So any doubts you can always post in the session. So today we are going to discuss episode 5, hepatobiliary and pancreas. Okay, we are going to start with hepatobiliary and pancreas topic today. Okay, we are going to start with hepatobiliary and pancreas topic for today's session. So any doubt, and good evening, welcome Harini, welcome, good evening. Yes, the first question for today is on a patient underwent cholecystectomy and presents to hospital with a bile duct stone after 2 years. What is the name of such stones? So classical question, NEET PG 2021. So there will be definitely a question from NEET PG exams from CBD stone. So this is a very interesting question. So NEET PG 2021, a patient underwent cholecystectomy and presents to hospital with a bile duct stone after 2 years. What is the name of these such stones? Yeah, please post the answer here in the chat box. So the name of such stones are after 20 years is known as what? Secondary stones, also known as recurrent stones. So let me explain you about this concept of CBD stones. So please remember, it is a clear-cut concept about the stones. This is a bile duct I'm drawing now. This is a bile duct. So this is a bile duct, and this is cystic duct. This is gallbladder. So all of you know very well, the stones are usually formed in the gallbladder and they jump into the cystic duct. From the gallbladder, they jump into the cystic duct and into the CBD. This is known as secondary bile duct stone. Okay, secondary bile duct stone. So please remember there is a small card. I'll answer this question now. So secondary bile duct stone is a stone which is formed in the gallbladder and come to the bile duct. This is secondary bile duct stone. If a stone is formed in the bile duct itself, it is known as primary bile duct stone. So please don't get confused in these concepts. So because during the exam time, always we used to get confused in this. A stone which is formed in the bile duct itself is known as primary bile duct stone. Okay. So always please remember the primary bile duct stone is always brown pigment stone. It's a brown pigment stone which is formed in the bile duct itself. Please don't forget, it is formed in the bile duct itself. So which stone is formed in the gallbladder and jumps into the bile duct means the most common secondary bile duct stone is mixed stone in India or over the world, mixed stone. So secondary bile duct stones are most commonly mixed stone. Primary bile duct stone is a stone which is formed in the bile duct itself is brown pigment stone. This is one classification of CBD stone. So classify the CBD stone. If they ask you, please remember there are two types, primary and secondary. Which is common? Can you tell me? The most common type is secondary bile duct stones are common. Okay, secondary bile duct stones are common. So now there is another classification. In this classification, a patient comes to you with a stone in the bile duct. But this patient underwent cholecystectomy. Please remember the gallbladder has been removed out. Cholecystectomy has been done, removed out, and no gallbladder is there. Now stone is formed in the bile duct. If a patient comes to you with a stone in the bile duct within 2 years, what do you call him as? And if they come to you after 2 years, what do you call it as? The patient comes to you within 2 years, you call it as, yes, retained stone or missed stone. If they come to you after 2 years, they are known as recurrent stones. See friends, I'm just taking half an hour session of all the important previous year question in each module. Only one more module is pending, that is specialty module. So I'm covering the important high yield aspects of the previous year questions. It is no use of reading any other content at this point of time. It is point of time where you should just revise the old questions. If you revise the old questions, definitely there are going to be same concepts again. So definitely this will help you. So retained stone is a stone which is found within 2 years, and more than 2 years is known as recurrent stone. Now tell me, what is the name of the stone for a patient who comes to you after 2 years? After 2 years. So after 2 years is usually a recurrent stone. Within 2 years is known as mixed stone. Sorry, is known as retained stone. So there is no choice of recurrent stone in this list. So recurrent stones are always brown pigment stones. So brown pigment stones are the stones which are formed as primary stones. So go for answer A. So there are three answers for brown pigment stone. Okay, three answers for brown pigment stone. Three answers for brown pigment stone. I want you to remember. Please remember, brown pigment stone is a very important high yield topic for your exam. This is a primary bile duct stone. This is the stone formed in the bile duct itself. Okay, number one. Number two, this is the stone formed in the bile duct after cholecystectomy after 2 years. After 2 years. Therefore, it is also known as recurrent stone. It is also known as recurrent stone. Which is the stone formed in the bile duct due to infection? Infectious stone is also brown stone. Infectious stone is also brown stone. Yes, correct, K. You are absolutely correct. You have read, I think you have read our surgery sixer contents. You are absolutely correct. We will discuss about it in future sessions. At this point of time, please remember, brown pigment stone is a stone found in E. coli infection, related infection, or in case of oriental cholangiohepatitis, or in presence of ascaris. So brown pigment stone is having so many MCQs. Brown pigment stone is a primary bile duct stone. Brown pigment stone is a recurrent stone. Brown pigment stone is a stone seen in infection. So what will you do for a stone which is found in the bile duct? That is nothing but primary bile duct stone. What is the treatment of choice for primary bile duct stone, also known as recurrent stone? What is the treatment of choice for this? So all of you know the treatment of choice for CBD stone. I will tell you about it later. But for a primary bile duct stone or recurrent stone, we open the bile duct vertically and anastomose it with a nearby bowel, either with a duodenum or with a jejunum. So this is known as choledochoenterostomy is a treatment for these cases. So choledochoenterostomy, we have to do a permanent procedure, that is anastomosing with the bile duct and the duodenum or with the jejunum. So this is the treatment for brown pigment stones. So please don't get confused with the treatment of other CBD stones. What is the common CBD stone? I told you. The commonest CBD stone what we see in our practice is a stone in the bile duct with a gallbladder stone. This is what you commonly see in practice. Now, very important question for your exam. Tell me how you are going to approach. I will give you a clue. The patient, Mrs. Kamala, comes to you, 40 years female, comes to you with a gallbladder stones, and she is having a CBD stone, 8 mm stone, causing obstruction. Patient having jaundice, pain, and fever. What is this? This is Charcot striate. Patient comes to you. So what will you do next? My question is, what will you do next? So don't get confused in the exams. What will you do next? What is the investigation of choice? What is the gold standard? So there are three questions for this case. A patient coming to you with a suspected bile duct stone, having jaundice, pain and fever. What will I do next? Next will be ultrasound abdomen. No confusion in this. Ultrasound abdomen will show me the bile duct is more than 8 mm dilated duct. CBD is more than 8 mm dilated. Very important. Investigation of choice is MRCP. Gold standard is ERCP. Please remember, sir, how to know whether it is investigation of choice in a question or it is a gold standard? How to differentiate these two investigations? Let me tell you, gold standard is one which is 100% sensitive and not done always. Please don't forget this point. It is not done always. Wherever you are reading gold standard, we don't do it always. It is 100% sensitive. It is the best, but it may be more complicated, more cumbersome investigation. So we won't do it always. 100% sensitive, not done always. Remember this. Investigation of choice is 95 to even 100% sensitive, but it will be definitely done. It will be done. Okay. Without it will be done definitely in all the cases. Please don't forget this point. It will be done in all the cases. So please don't forget this is very essential. Very essential point. Investigation of choice will be always done. Gold standard doesn't need it to be done. So ERCP in this case will help in diagnostic as well as therapeutic use. Okay, diagnostic and therapeutic use. ERCP is going to help in a case of cholangitis. So any doubts, you can always post. I'm watching your chat box. Yes, Karthik, you are correct. It is diagnostic and therapeutic. MRCP is the investigation of choice. Gold standard is ERCP. So there will be definitely a question related to concept of CBD stone. Please don't forget a question related to concepts of CBD stone. CBD stone, the answer for this, what is the name of such stone is primary stone. So the actual answer will be the name of such stone is recurrent stone, but they have not given recurrent stone in the choice. So what is recurrent stone? It is a brown stone. Therefore, which other is brown stone? Primary stone. So indirectly, I'm going for A. Indirectly, I'm going for A. Please remember this. Okay. So question number 2, related concept. So if you are answering, I'm telling you, if you are knowing all these 6 questions thoroughly when I'm discussing, you can go confidently to the exam, because the 6 questions I'm discussing are all directly NEET PG questions taken by the same examiner who is going to set question paper this year. So if you are going to know answer for these questions, I'm sure you are going to crack excellent rank and mark. Okay. 65 years old female presented with increased SGOT, SGPT, bilirubin, alkaline phosphatase. Increased SGOT, SGPT, increased alkaline phosphatase. Please remember. She has the following ultrasound finding. Sclerotic atrophy gallbladder, large impacted stone in the CBD, distended CBD with a dilated intrahepatic radical. See the same question which I now discussed. See, I told you a discussion which will come, that has come here. So large impacted stone in the CBD. Okay, there is a large stone in the CBD, and gallbladder is having atrophic gallbladder, dilated radicals. This is ultrasound finding. Ultrasound will be showing dilated intrahepatic radicals. In this question, what is the best treatment? You can see best treatment. I will tell you what they are not asking. What is the next investigation, or what is the investigation of choice, or what is the gold standard? They are not asking. They are asking you, how will you remove the stone in the CBD now next, which is the best treatment for this CBD stone? Answer automatically comes as ERCP, not cholecystectomy. See, I'm seeing some of you are answering cholecystectomy. How can cholecystectomy be a treatment? Cholecystectomy will be done later. Yes. Now this patient is having obstructive jaundice because of the stone obstructing. They are having elevated SGOT, SGPT, alkaline phosphatase. So my first aim will be to remove the stones by ERCP. That is the best treatment also. That is a gold standard treatment, gold standard investigation also. But please remember, no medical gastroenterologist is doing ERCP after doing an ultrasound. Always they do an MRCP as a roadmap. MRCP is a roadmap before any procedure. All of them are doing this procedure of MRCP. So please don't forget this point. Okay. So any other doubts, if you have, please tell me related to this topic, because I want you to have any doubts related to CBD stone. Definitely you should ask me here itself. This answer is ERCP. The best method to manage a CBD stone is ERCP, sphincterotomy and stone removal. The question based on the protocol for the CBD stone protocol I showed you just few minutes back. I showed you the CBD stone protocol. Okay. Now in biliary system chapter, I want to tell some important MCQs. Gallstone. See, gallstone. Acute cholecystitis. I'm going to tell some important points. Gallstones, acute cholecystitis. Okay. Gallstones, acute cholecystitis, CBD stone. Okay, CBD stone. So each one, I have told you important point. What is next? What is the investigation of choice? What is the gold standard? For a gallstone, next investigation as well as investigation of choice, both are ultrasound abdomen. I hope all of you know the findings of gallstone in ultrasound abdomen. Ultrasound shows a stone in the gallbladder which will have a posterior, what finding? Posterior acoustic shadow. Gallstones, ultrasound abdomen is more sensitive than CT scan. Please never ever forget this for your lifetime. Ultrasound is more sensitive than CT scan for gallstone. It will show you posterior acoustic shadow. Acute cholecystitis. What is the next done investigation? What is the investigation of choice? Again, the same answer, ultrasound abdomen. Acute cholecystitis will have thickened gallbladder wall more than 3 mm. 3 mm thickened gallbladder wall. Pericholecystic fluid may be present. What is the gold standard for acute cholecystitis? Never ever forget. That is HIDA scan. HIDA scan is the gold standard. It will show you no gallbladder. Non-visualization of gallbladder. Non-visualization of gallbladder is HIDA scan. But it is not the investigation of choice. That's what I want to tell you here. Acute cholecystitis, investigation of choice is ultrasound. Gold standard is HIDA scan. I told you what I told you, gold standard. Gold standard is not always done. It is done in extreme doubtful cases. CBD stones, next is ultrasound. Investigation of choice is MRCP. And gold standard is ERCP. Okay, please don't forget. Every point is important, especially during the exam time. You should not forget all these essential investigations for your exams. Let me not take most of your time. I just wanted to finish up the session in 30 to 40 minutes maximum. If you have any doubt, I will clear it. Otherwise, I will finish it off as early as possible. Yes, very good, Kavin Durai. It is post-acoustic shadow. What is the most common site of Gastrinoma in MEN1 syndrome? See, Gastrinoma is the most common neuroendocrine tumor in MEN1 syndrome. So all of you know that about Gastrinoma. Gastrinoma is usually seen, if it is seen sporadically, it is common in Passaro triangle. Please remember what is Passaro triangle. Passaro triangle is 3 points. Neck of pancreas, second and third part of duodenum, second and third part of duodenum, cystic duct CBD junction, cystic duct CBD junction. So this triangle is known as Passaro triangle. This triangle is known as Passaro triangle. So Passaro triangle is a triangle of Gastrinoma. Gastrinoma, the most common site of Gastrinoma is Passaro triangle. So please don't forget, this is the most common site bounded by cystic duct CBD junction, neck of pancreas, second and third part of duodenum. But the question is very clear, asking about MEN1 syndrome. MEN1 syndrome, the most common site is duodenum first part. Okay, duodenum first part is a common site. It is in the first part of duodenum is also in the Passaro triangle only. But if they ask you specifically in MEN1, you should go for D1. But if choice is having Passaro triangle, you should go for Passaro triangle. Since the choice in this question, there is no Passaro triangle mentioned. See the question. In this question, there is no Passaro triangle mentioned. So I am going with duodenum. So most of you might be thinking Gastrinoma is common in pancreas. No, Gastrinoma is common in duodenum. First part of duodenum. First part of duodenum is the place where it is most commonly seen. I request you, please remember, Zollinger-Ellison syndrome is a clinical feature of Gastrinoma due to excess gastrin produced. Excess gastrin produces increases the acid and causes severe refractory peptic ulcer disease. Refractory peptic ulcer disease is seen, followed by there may be refractory peptic ulcer disease or there may be diarrhea. These are the features of Zollinger-Ellison syndrome. Investigation of choice to diagnose is serum gastrin, which will be more than 1000 picogram per ml. If you have a doubt, we have to do secretin stimulation test, which will have immediate increase of 200 picograms from the baseline value. There will be an increase. So Gastrinoma is mostly malignant tumor, so we have to do Whipple's operation for those cases. So please remember, this question is a simple question, but it is highly expected. Again, Gastrinoma is an expected MCQ for your exam. What is the location investigation? How will you locate where is the Gastrinoma located? Is by SRS, somatostatin receptor scintigraphy is used to locate Gastrinoma. Yes, Vivek Armagam is asking about Insulinoma. Insulinoma is commonly located in which place? Insulinoma is equivalent head, body, tail. It is the most common neuroendocrine tumor in functioning neuroendocrine tumor in functioning. Please remember, I'm not telling non-functioning. Functioning neuroendocrine tumor in the sporadic is insulinoma. It is equal in head, body, and tail. It is benign. Okay, investigation of choice to diagnose insulinoma is 72 hours, fasting blood sugar, insulin level, C-peptide level will be measured. So, insulinoma is presenting with a clinical feature of Whipple striatum. Whipple striatum is signs of hypoglycemia, blood sugar less than 40, relieved by taking sugar. That is Whipple striatum. And please remember, insulinoma is located by, it cannot be located by SRS because insulinoma lacks somatostatin receptor scintigraphy. Therefore, I should use intra-op ultrasound or endo-ultrasound. If it is in the choice, you should go for endo-ultrasound or intra-op ultrasound is the best answer for insulinomas. Okay, simple question. Please don't make mistake about this. So, MEN1 syndrome, all of you know it is Wermer syndrome. MEN1 is Wermer syndrome. It is autosomal dominant. It has 3P: parathyroid, pituitary, pancreas problem. In the pancreas only, the second most common, first most common manifest is hyperparathyroidism. Second most common is neuroendocrine tumor of pancreas and duodenum, which is seen in 30 to 80% cases, and they can have prolactinoma. And most common pancreatic tumor is gastrinoma. Please don't forget this point. So they can also have carcinoid tumors. Most common cause of mortality in MEN1 is duodenal and pancreatic tumors or intrathoracic carcinoids. So please don't forget that pancreatic tumor is nothing but the gastrinoma. Gastrinoma is the most common cause of death in MEN1 patients or intrathoracic carcinoids. So the two causes are these two. Okay. So insulinoma or gastrinoma, what you are asking, Vivek? Vivek, Arumugam, most common. Please understand this question. All of you should not make mistake in the exam. Usually the examiners will not try to confuse you. Most common neuroendocrine tumor of pancreas. What is the answer for this? Answer is PPoma, pancreatic polypeptidoma, but it is non-functional. It is non-functional, so you won't see these patients. Insulinoma is the most common functional. In MEN1 syndrome, answer is gastrinoma. Overall, it is insulinoma. MEN1, it is gastrinoma. So don't get confused in these three choices. Three questions are there. VIPoma is a very rare endocrine tumor. VIPoma is a rare neuroendocrine tumor seen in the tail of pancreas, and it is presenting to you with the Werner-Morrison syndrome. Werner-Morrison syndrome, also known as pancreatic cholera. They come to you with a pancreatic cholera, also known as WDHA syndrome, watery diarrhea, hypokalemia, achloridria syndrome. Watery diarrhea, hypokalemia, achloridria syndrome. Okay, watery diarrhea, hypokalemia, achloridria syndrome. So let us move on to the fourth question. So whenever you go and read liver chapter, so in liver chapter, they will definitely ask you scores. Two important scores you should know are King's College score and MELD score. A 5-year-old child presented with acute fulminant liver failure. Which one of the following criteria are not included in the King's College criteria for liver transplant? I request you to download 40 pages of last minute revision scores in surgery. I have uploaded in my Telegram channel long back. Telegram channel, Surgery Sixer. The Surgery Sixer Telegram channel, I have uploaded it long back. Please see this in my Telegram channel. Surgery Sixer, last minute scoring and criteria classification I have uploaded. Please download it from Surgery Sixer and read it. Okay. So, and in that, this criteria is also there. King's criteria not included for acute fulminant liver failure. So, age, prothrombin time, bilirubin, and jaundice less than 7 days before development of NCOF. Which of the following criteria is not included in this? Answer is, please follow this protocol. This is a table showing you just leave this question, just read the concepts of this question alone. So there are two types of King's College criteria. One is for paracetamol induced. So, and another is for non-paracetamol induced, because it's a poor recall by the students because they could not say whether it is a paracetamol induced or non-paracetamol induced. Paracetamol induced, please remember, pH, if it is a question on paracetamol induced, the answer is if pH less than 7.3 or prothrombin time increased with a serum creatinine more than 300 micromole. So please remember, pancreas will attack the kidney also. Remember that. Paracetamol will attack the kidney also. Paracetamol attacking the kidney with the prothrombin time more than 100 seconds is paracetamol induced. So, but this question was probably asking about non-paracetamol, which is prothrombin time more than 100 seconds, or any three of the following. Probably this is a question on any three of the following. So, age less than 10, more than 40. Bilirubin more than 300. Non-A, non-B halothane drug reaction cases. More than 7 days jaundice, prothrombin time more than 50 seconds. 5 factors. So probably this question has to be modified. Which one of the following criteria is not included in the non-paracetamol induced King's College criteria? Means age less than 10 years included. Prothrombin time more than 50 seconds included. Bilirubin more than 300 micromoles is included. Jaundice less more than 7 days. You can see jaundice more than 7 days before encephalopathy. It is not less than 7 days, more than 7 days. So this scoring is little tough score, but this score has come at least 3-4 times King's College criteria. Even 28th edition of Bailey and Dow has updated about this score. So please go through this paracetamol induced thing. Okay. So encephalopathy is always 3 or 4, not 1 and 2. So this is irrespective of grade of encephalopathy is for pH when it is less than 7.3. But if it is another criteria in paracetamol induced is prothrombin time more than 100 seconds, creatinine more than 300 micromoles, encephalopathy 3 or 4 is included. 3 or 4 is included. Okay, not this thing. So this question is asking what are the non-paracetamol 5 factors: age, bilirubin, etiology being non-A, non-B, more than 7 days jaundice, and prothrombin time more than 50 seconds. So I want you please remember about the factors asked in modified child book score is again another important MCQ. Modified child book score you should read. It includes BAPI. This question came in FMG exam also. What are the findings in modified child book score? Bilirubin, ascites, albumin, prothrombin time, and encephalopathy. There are 5 findings are asked in modified child book score. So the next question is coming up on MELD score. What are the findings included in MELD score? What is the latest MELD? What is the latest MELD including? CBI is a MELD which is used old books. Now latest MELD uses sodium CBI. Okay, sodium is also included in CBI now. Creatinine, bilirubin, INR. Logarithmic value of this is used as MELD score. Please remember, it extends from 6 to 40. The value is 6 to 40. When it is more than 50, we put the patient under waiting list for transplant. Waiting list for transplant is based on this score. When it is more than 15, we have to put the patient under waiting list. So now there is an expected MCQ. MELD score is used for cadaveric liver transplant. What are the exceptions to MELD? Exceptions to MELD score. Where all MELD score may not be needed. MELD score exceptions. Or where are the places where we cannot apply MELD score? Means number 1, amyloidosis. Number 2, HCC. These are exceptions. We cannot wait for the score to become above 15. In yearly values itself, we will take for surgery amyloidosis and HCC. Please don't forget this. MELD score is used in yearly cases also. Okay. So I hope MELD score is again another interesting MCQ topic. Please don't forget MELD and King's College criteria. Which of the following is false about chronic liver disease patient? NEET PG 2019 question. See the question. MELD is used for liver transplant. True. MELD has CBI. Okay, nothing is there. Prothrombin time, INR, albumin, creatinine. It is not CBI does not contain albumin. So answer is B. B is wrong. Child Pugh score, modified child Turcotte Pugh score contains ABC. Three grades are there. That is true. As INR, albumin, and bilirubin, three are included in this. So INR, albumin, bilirubin is also included in the BAPI. So BAPI prothrombin time is nothing but INR. Encephalopathy, albumin, bilirubin, everything is included in child Pugh score. Okay, the answer here is B. MELD score. Simple question asked in when this question came in the 2019. Most of the students were new for this topic at that time. So from then onwards, it has become a standard landmark question for all the exams. So you should be thorough with MELD score. MELD exceptions, don't forget. MELD exceptions are where all you can skip the MELD score and take for a transplant is for amyloidosis HCC. Okay. The last question for Sensational 6 is regarding the complications of Whipple's procedure. Regarding the complications of Whipple's procedure. Definite another repeat question for your NEET PG exams. Most common complication is delayed gastric emptying. Most common cause of death is PJ leak. On third post-op day, if DT fluid amylase is 5 times, it is fistula. Bleeding is a worrisome complication. Which is wrong in this answer? Can you tell me? A, B, C. Yes. Consistently, I'm seeing some of you are answering very well. Kavindurai, Karthika, Sri Krishna, all of you are answering perfectly. What is the answer for this? Answer is C. Okay, I'm going to tell you. This is rule of 3. And the answer is rule of 3, not 5. It is 3 times. So please understand Whipple's operation, another favorite high yield topic for national board exams. Every FMG exam is getting this question. So this is the image of what surgery was asked in the exam. This is a Whipple's operation. So Whipple's operation, I'm going to explain you now. So please don't forget, Whipple's operation is one of the major dream surgery of the surgical gastroenterologist. So we always love to do Whipple's operation. So this is the neck of pancreas. Don't forget this. And this is bile duct. This is gallbladder. This is common duct. Okay. Now, in a Whipple's operation, for who all will you do Whipple's operation? Basic point, it is done for pancreatic head cancer and distal CBD cancer. See, head of pancreas cancer, distal CBD cancer, and duodenal second part cancer, and periampullary cancer. These are the 4 cancers you do Whipple's. So, periampullary, head of pancreas, distal bile duct, duodenum. All these cases, I will do Whipple's. I will cut the pancreas at the neck of pancreas where the superior mesenteric vein enters and comes out as portal vein by joining with the splenic vein. So I have to cut it at this place. So what are the structures I am going to cut? Please don't forget. I will remove the up to this part of pancreas. Distal stomach I will remove. Entire duodenum I will remove. Entire duodenum. See, first part, second part, third part, fourth part I will remove. And gallbladder and bile duct I will remove. So whatever I have highlighted, I will remove. And anastomose the remaining pancreas, remaining bile duct, remaining stomach. So these are the 3 structures I am going to do anastomosis. 3 anastomoses are PJ, GJ, HJ. 3 anastomoses are done. So Achilles heel of this operation is PJ. Achilles heel. Achilles heel means most important step. If this leaks, most common cause of death. Most common cause of death is this. Okay, most common cause of death is this. Achilles heel is the most common cause of death. Very good, Sri Krishna, that's correct. So GJ we are doing, no, this may not empty properly in 20% of the cases. That is called as delayed gastric emptying. Delayed gastric emptying is in 20% of the cases. That is the most common complication. Okay, most common complication. Another complication is bleeding. Bleeding is usually from one important artery here known as GDA. GDA is a most common cause of bleeding. Okay, the GDA which we have tried, no, that is a common cause of bleeding in post-op period. Okay, please don't forget. And after Whipple's operation, we always keep a drain at the anastomotic site, so that if there is any leak coming out, we will find out, okay, the anastomosis started leaking like that. So for that, There is a definition on third post-op day. DT, the fluid is coming, no, that amylase is 3 times that of serum amylase. We call it as what? If third post-op day DT fluid amylase is 3 times more than the serum amylase, we call it as 3 times the serum amylase is known as leak, pancreatic fistula. Pancreatic fistula. So please don't forget this thing, okay? This is a very important topic for exam. So Whipple's operation. One more operation, they tried to preserve the pylorus like this. So instead of cutting the stomach, they preserved the pylorus like this and they did a GJ. So this pylorus preserving Whipple's is known as Longmire and Traverso. Longmire and Traverso. This is removed in recent Bailey. This is also a type of Whipples, pylorus preserving Whipples known as Longmire and Traverso. Thank you, Gautam. Thank you so much. Hope this sessions also will be very useful for all. So I have completed the 5 sessions of Sensational 6 series, and one more series is awaiting tomorrow. Tomorrow probably I will do that, urology, vascular and plastic surgery. So thank you all for attending the session sincerely. I don't want to disturb most of your time because you all will be very serious with the exam just in 5 more days. So keep preparing well. All the best. Just share this video with your friends. Let them also get utilized. So whatever I'm discussing in the Sensational 6 series are pure repeat questions and which are highly expected questions in exam. So order of anastomosis is always like a PJ. Karthika is asking what is the order of anastomosis in Whipple's. Order of anastomosis is PJ followed by HJ, followed by GJ, and followed by FJ. Feeding jejunostomy we will do sometimes. Not for all patients. Some patients we will do feeding jejunostomy. So first anastomosis PJ, second anastomosis HJ, third anastomosis GJ. At this point of time, you should ask me a question. How will you do the anastomosis? PJ using a proline sutures. Pancreatic duct is sutured with proline. Hepatico-jejunostomy with the 4O vicryl known as polylactic acid. GJ is done with the help of 3O vicryl, that is polylactic acid. So what suture material will you use? Should be a question now. Proline is used for this thing. Okay, proline as memory. Yes, you are very much ready for the exam. Sri Krishna, all the best. Thank you all. Hope you all will be utilizing these sessions. Thank you all. See you soon in the next session tomorrow. Bye.